Good morning, good afternoon, good evening, everyone. I am Dr. Neena Valicha, Chair of Vivax Working Group and Senior Technical Advisor MMB. Formerly, I was Regional Advisor at WHO Southeast Asia region. Today, it's my privilege to welcome you all for this webinar on G6PD testing for radical cure of Vivax malaria, current implementation and gaps. And this webinar is being hosted by Asia Pacific Malaria Elimination Network, APMEN. Let me add here that APMEN is a collaborative network comprising of national malaria programs and partner institutions, and this network facilitates technical exchange through its working groups like we are doing today. And APMEN Vivex working group is supported by Dr. Caroline Lynch, co-chair and MMB regional advisor, Dr. Manas Shrestha, technical coordinator, who is very much here, Dr. Fons Sehain, associate director, APMEN. And this group has been working on implementation challenges faced by countries and supporting them with decision making for new tools for Vivex radical cure. So today's focus is on radical cure. And when it comes to radical cure of Vivex malaria, you will all agree with me that even as countries move closer to malaria elimination in Asia Pacific or other areas, appropriate and complete, mind you, complete treatment remains a challenge when it comes to radical cure. And safe administration of this radical cure with primaquine and tefenoquine hinges on the reliable testing of G6PD deficiency. Since these are ateminoquinolines and they can cause hemolysis in G6PD deficient individuals. So while we do have the point of care diagnostics available now, and also the new medicines and new tools, but the implementation remains a challenge. Now, today we will try to dwell into implementation progress and realities as well as the lessons from the field, which is very relevant for the programs when they start implementing any new tool or technology. In addition, we'll try to understand the critical gaps which may be there for access, affordability, quality, and training issues. And I'm sure our distinguished panel today will share their experience and the perspectives and also the evidences for these implementation issues. So let me give some housekeeping announcements. We will be the audio and visual video of attendees will be disabled, but you can post your comments in chat box as well as questions in Q&A box. And of course, we'll have all the presentations first, which will be followed by Q&A sessions. And please do specify the speaker to whom you are addressing your question and also your name so that we can respond. And if, in fact, you can put your questions as the lectures are being there, and we can address it along the presentations or at the end. And also there at the end, there will be a quick Zoom poll regarding the webinar. So now let's start the session. And it's my honor to invite the first speaker, Penny Greva, who is Senior Technical Advisor at Medicines for Malaria Venture. She has held leadership roles in access and delivery within MMV and is active in advancing malaria treatment and diagnostics, particularly in relation to Plasmodium vivax and G6PD deficiency, and she will be presenting those aspects. And Penny will reflect on especially the lessons learned from operational research and also provide key consideration for introducing G6PD testing for radical cure of vivax malaria in the region. Over to you, Penny. Your speaker is off, Penny.
Sorry, good morning, everybody. Let me start by sharing my screen. Sorry, here we are. Apologies, here we are. And slideshow from the beginning. Sorry, previous. Good morning, everybody, and apologies for that short hiccup. I'm delighted to be presenting the results from and insights from our operational research and implementation. And what I'll be presenting is really a collaborative effort that we have made, me and my colleagues and all our partners, together with ministries of health around the world and research partners, and of course with Path, who has been instrumental in supporting the development of the SD Biosensor G6PD test. As Dr. Nina has already said, G6PD testing is really a game changer because it's facilitated the selection of appropriate, well-tolerated, and potentially shorter and therefore more effective Vivax radical cures. This means that depending upon the G6PD activity of the individual, the person can either get a single dose tefenoquine or the short course high dose primaquine, or 14-day primaquine, or either weekly primaquine or no liver stage treatment. And depending upon the drug, it is given with either chloroquine or ACT as a blood stage treatment. There has been a growing footprint of G6PD testing across Latin America, which began in Brazil with the famous TRUST study that was led by Dr. Marcos Lacerda and Delio, then moving on to Peru, and then other countries which are now piloting or planning to scale up G6PD testing in their countries, with or without tefenoquine. And the same thing in the Asia-Pacific region. There's been a huge increase in the footprint of countries either piloting or deploying the G6PD test. So what have we learned over all these years? I'd like to really start with talking about training, because training is the real strong foundation of using G6PD tests properly. And one of the key things that we've learned is that you really need to tailor your training content to the group of healthcare professionals we are talking to. So that means if you're talking to technicians, then it's really performing the test. Physicians, it's much more talking about the G6PD based treatment algorithm. Everybody should be taught how to talk to patients, explaining the test, why it's being done, what the results are, why a given treatment is chosen or not. We've also noticed that the best training is really bringing one which brings together both theory and practice. And that ensures that people can actually be confident using the skills. Presentations, not overloaded visual aids, trying to reduce the cognitive overload in slides. And one thing which we've learned from our recent study that Nina and I have been involved in together with the National Institute of Malaria Research in India is updating the slides once we've had a training session to really bring in the questions that were asked or concerns that were raised. The other thing which is critical, particularly with G6PD testing, is the practical element. This interactive training, I think we've all been in so many training sessions where we actually just zone out because they're just lecturing us. And therefore, it's really important to be able to break your sessions up in order to have participants ask questions, engage, and really be part of the training session. The hands-on practice is, as you know, important around G6PD testing. And what we've realized is that a small ratio, what we've organized now in our multiple training sessions, is trying to have round tables where you have about 2 analyzers for 4 to 6 participants. This ensures everybody has a hands-on feeling with the G6PD test, can try, experiment, and learn how to use it properly. And then also sharing the competency checklist while you're running through the theory is very good, because then people can understand what is required and what are the different steps and can keep track of what is being done. The post-training follow-up is also equally important because the competency assessment is very, very critical. And the question is, what is the best time for that? What we've learned is that doing the competency assessment immediately after the training can be complicated because health workers have to rush back home. And typically, then you either have to compromise on the time for them to practice. And so what we've found is that it's maybe best to do the competency assessments when you're distributing the G6PD test kits, if that's possible, because there's typically a lag between the training and the distribution of the tests. So this means that then they get a refresher course before they start using the test, and then they have another one-on-one chance to use the test and then do the competency assessment, and also remember the areas which they didn't get correct in the first place. The other thing is then a follow-up at the workplace also allows you or the team to try to incorporate methods into what their workplace looks like. Refresher training is critical to maintain skills, especially when you have a lot of high staff turnover, which unfortunately happens. And this possibility of having a few people at the same health facility knowing how to do the G6PD test provides a backup and also provides the possibility for peer-to-peer training. The other thing which is also critical to remember is there has to be access to tools and resources for continuous learning. One thing that we started in Brazil, which was fantastic, was just real-time creating a dedicated messaging group for WhatsApp. And then Dr. Prayut did the same thing in Thailand with Line, which provided the possibility for people to really ask questions when they were stuck. And then having one person who was dedicated to answering those questions. And then putting together all these frequently asked questions where people can actually access them and have access to all these usual questions, the common questions that people ask. What we've also learned is it's really critical to have your materials in the local languages. We just finished a study in India. Although we did all the training in bilingual, then the job aids have to be in the local language so people can understand that. And then these short videos about different steps of G6PD testing or the treatment guidelines or treatment algorithm, sharing them on WhatsApp or YouTube are really good references for people to access. On our Vivax Malaria website, you have a host of materials. Please don't hesitate to go there, to download them, to edit them. And if you need any high quality images, don't hesitate to contact my colleagues. Supportive supervision, as you know, is really critical. It enhances confidence. And this can be both remote and on in-person supervision. One thing which we've found has been very useful is just open discussions with healthcare providers to really understand what worked, what didn't work, what needs to be fixed, where they have concerns and questions. And this gives them much more confidence. And as you know, we always have routine supervision and malaria control. So why not just leverage those to check performance, to provide refresher training, to review stock levels, expiry dates, and any operational challenges. The main thing is we really need to embed everything around G6PD testing in our routine system. The other thing which works really well is getting support from the local health system leaders, whether it's local, district, or regional level, because that's extremely motivating for the local health workers. And also engagement of the community around, because it's community-led monitoring and it helps, it works, and it's very positive. Now, if we switch gears and look at procurement, because that's another key element, is how do you make sure that you actually don't have stockouts? I think one of the key considerations that we've worked around is saying, okay, first sitting down and thinking is where are you going to deploy the tests? Which areas are you going to prioritize? Are these high burden areas, areas close to elimination? What is going to be the key criteria? What type of health facilities? If I think of Thailand began with the hospitals and then subsequently moved to the malaria clinics. In Brazil, they chose areas and municipalities, but all the health facilities in those municipalities. And then the question is also, how are you going to scale up access over the next 4 or 5 years? Then considering how many G6PD tests are needed, here we really have to think about what's needed for testing. That means looking at the number of Vivax cases you have and also mixed infections. How much you need for training, because you need to have tests for training. And there, for example, if you have expired tests, you could really use your expired tests for training as well, so that you don't waste them completely. And then quality control clearly needs G6PD tests. And please don't forget buffer stocks. The good news is SD Biosensor provides 2 pack sizes with 20 tests or 10 tests. And so depending upon the type of facilities, the caseload, you should try to think of a breaking up of the volume by the test kit size. And please remember, you cannot split a pack. because each pack has a unique chip which goes with that batch. Think of staggering orders and deliveries to maximize shelf life, because the test kits have a shelf life of 18 months, controls of 12 months. And the other thing is, please don't forget to order more easy tubes. You can get extra packs of just easy tubes. These are the pipettes to be able to transfer, to mix the materials and to transfer the mixed material into the onto the device, because the packs only come with exact number of G6 of easy tubes. And then, of course, you will need the other elements which are not included in the G6PD test kits: the gloves, the cotton, and the lancets. Quality control is, of course, very, very critical, so that you can rely on the results. And this means you've got to think about a quality control plan, both for the country and then for each level of the health system, because your QC at lower levels is probably going to be less frequent than at higher levels. And that should be integrated into your supportive supervision. And it's critical to assign somebody responsible for QC, and ideally try to find a day on which you do QC, so it just becomes part of the routine of that person's work. The first Monday of the week or the first Monday of the month or whatever it is. It just helps people remember. And then, according to the instructions for use, quality controls checks have to be done, which are using a control, a high and a low level control, whenever you use a new G6PD test device or when the result seems incorrect. Surveillance systems are important. Once we start introducing G6PD testing, we need to update our surveillance forms, both the paper and the digital forms, so they capture the G6PD activity and hemoglobin levels, and most importantly, also the treatment decision. This is what was done in Brazil, which is absolutely brilliant, is the alerts set up when the G6PD activity and the treatment chosen do not match, because that can give you an alert as to which health facilities are making a mistake, because that means you need to retrain the staff immediately, either virtually or in person. This serves as an excellent system for pharmacovigilance as well, because this allows you to scale up access to shorter course treatments, but still keep an eye on how the system is actually incorporating the new G6PD treatment algorithm and the G6PD tests, because this allows you to track safety, identify issues early, and also to fix them early. So in a nutshell, what we found all around the world, whether it's Brazil, Thailand, Peru, India, and in Southeast Asia, is that incorporating G6PD testing into routine care is really highly feasible. Healthcare workers are motivated. They're really eager to use new tools and learn new skills. We were amazed by the enthusiasm health workers, particularly when they get involved and they use the devices. That is really extraordinary, and that's something we can all build upon. We found extremely positive results from both the operational feasibility studies and the subsequent introduction from routine care. Health workers, when they start, they have concerns, but these are really resolved with experience. The most important is everyone is worried about the increased workload, because this means the patient flow changes. When do you introduce the G6PD test? It means not just doing the malaria test, then those who are Vivax positive or have a mixed infection have to be tested for G6PD activity, and then that goes back to the physician or the health worker who makes the decision. And particularly in the high season, in the high transmission season, there are a lot of patients, there are a lot of testing. But the G6PD testing only takes another 4 minutes or 5 minutes. So it's not such a game changer, but in the beginning, it adds to the nervousness of the health workers. The other thing which is interesting is the health workers get typically very nervous about doing the G6PD test in front of others at the village or the community level. And this is normal. Sometimes they don't even, if they're going to the village level, they might not even have a table to put their tests on, all the different the buffer and everything on, and they have to improvise. So they all get nervous. But then once they get into the swing of it, this nervousness goes away. And the other thing we found is that the health workers get really concerned if they do get somebody with G6PD deficiency, and they typically try to repeat the test just to be sure. And then slowly but surely they gain confidence. And as was said very nicely by one of the health workers in Portobello, and say, before we start, we are kind of slow when we handle the device. Today it is faster to do because at the beginning it takes us a little longer because we did the step by step. And then we feel safer doing it. And to me, the words of Myrna are the most appropriate because she said, everything new is scary. So at first people said, oh, it won't work because people won't want to get tested. They'll forget about doing the G6PD test to start defenacin treatment. And today everybody knows the treatment is routine. Everyone knows that in order to take defenacin, a G6PD test is needed first. And that's really true because we learn and then we slowly embed that and we know what to do. And so this is why we are now confident that you can actually incorporate G6PD testing in routine care. My colleagues and all the researchers involved have actually developed what we call our lessons learned from operational research. And we have that available on our website, which you can which you can easily download if needed. So I'm going to stop on that note and hand back to Nina. Thank you, Nina.
Thank you. Thank you, Penny. I mean, for sharing your valuable insight and especially on the training aspects. And I'm sure the lessons learned will go a long way for facilitating adoption of these new tools, especially in the public health programs. And, I like that statement that when you go for training at any facility, I mean, they say everything new is scary. I mean, that is very true. And also the aspects that when you related to the assessments and also the retraining aspect. So these are very practical issues which really when you work on the ground you learn that, and it may be different in different scenarios although, but still there is a message and the perspective which we learn for engaging in the other countries. Thank you for sharing that, Penny. That thank you very much. Now, I would like to invite Dr. Lindiswini, and Dr. Lindiswini is a medical officer with the National Vector-Borne Disease Control Division under Ministry of Health and Medical Services, Solomon Islands. He oversees the case management unit, and he studied at the University of Papua New Guinea and has authored a lot of research papers on malaria, including treatment trials in pregnancy and studies on primaquine-induced hemolysis. Dr. Lindis will share the experience of deploying point of care G6PD testing in Solomon Islands and reflect on the challenges and potential solutions from the perspectives of National Malaria Program. Over to you, Dr. Lindis.
Thank you very much. If I can just share my screen. Okay. Thank you for this opportunity to share the experiences from Solomon Islands. Can you see my screen?
Yes. Can you please switch the slide? Now we are seeing the note of the slide. Could you please switch?
Can you put in presentation mode, please?
Presentation mode, just a second.
The third one, use slide slow. The third button on the top.
On the top, you can see,
top,
yeah, on the
top,
right one.
yeah.
Yes. Thank you.
Okay, yes, I'll be sharing the experience from Solomon Islands, basically the gaps. So in Solomon Islands, it's a very big country. Not a very big country, sorry. It's a country that's enclosed by around 159 million square kilometers of sea water. So we're just around 900 islands divided into 9 provinces. And if you can see from this map, most of the activities is in the area with the circle, which is Honiara on Guadalcanal, the main island. So most of the experience would be coming from Guadalcanal, and also we started the implementation of a phased approach, beginning with the 3 zones in Guadalcanal and the capital district, which is Honiara. Just a brief summary, just so we can have an idea on what the country is like and probably appreciate the difficulties that we do face. So it's a maritime country. Like I said, only 29,000 square kilometers of land. In total, we have about registered approximately 374 health facilities, of which 300 to 330 are functioning at any point during the year. By coverage, it's mainly public-run facilities and church-run facilities. We have a very small private sector with only about 10 to 15 facilities, mostly in Honiara, and they provide outpatient services only. So why do we need G6PD screening? And just like Dr. Penny has said, there's a lot of reasons, and one of the paramount reason is the risk of hemolysis with 8-aminoquinolones. And WHO recommends that G6PD testing before the prescription or patients getting 8-aminoquinolones. And for us in the country, implementation issues are the problem, not so much evidence. I think there's a wealth of evidence already produced around the world in terms of the safety and the use of G6PD screening in conjunction with prescription of the 8-aminoquinolones. So it's not so much evidence, it's more the challenges. And these, from our experiences, boils down to systemic challenges, whether the country is ready for implementing G6PD screening. Currently, there's no routine nationwide point of care testing, and testing so far have been limited to pilots and research activities. And most of our rural facilities are too far off to maintain a constant supply of reagents. And the facilities themselves, we have recently had to send back 12 out of the initial 40 machines that we brought from SD Biosensor. Most of the errors were due to environmental temperature errors. And given our location in the Pacific, that is a real challenge to us as well, to maintain them in the most ideal environments. For us, the unknown G6PD status actually leads to conservative prescribing. And by that is the reluctance of health workers to prescribe Primaquine to patients, which limits the use of Primaquine for radical cure. In addition, we have issues with adherence to the 14-day Primaquine, which is still challenging for us. And there's the systems do not allow so much to follow up for adverse events. So we do not have a lot of pharmacovigilance data on adverse events due to Primaquine in country. And one of the issues that we also learned, and it was good to hear from Dr. Penny that, to establish a well-functioning screening program, we need very good routine quality control and external QA systems as well. And the country is progressing into trying to improve those systems of quality, which is results in the variable clinician confidence with the results of a new test. So like I mentioned a bit earlier, is the unknown status for G6PD does actually lead to conservative prescribing, and along with the country's limitations in follow-up for adverse events through any established pharmacovigilance programs. Like I mentioned, there's limited standardized SOPs, but fortunately, as was mentioned, we do get most of our materials from the Vivax website, which we've adapted to the country situation. Our guidelines, we're still transitioning and trying to adapt to WHO-aligned dosing, and our procurement and regulatory pathways are still evolving. There are scale-up plans which have not been fully operationalized as yet. The other issue we have is with monitoring of the G6PD results. It's we have limited integration into our DHIS2 system for reporting. So the program does not have the visibility to monitor the safety and the impact G6PD screening actually has on increasing use or adherence to primaquine treatment. In the country, there's from several studies, there's evidence of moderate to high prevalence in some provinces, and mainly it's in the provinces. If you recall, I'm sorry, but if you recall from the first slide I put with the map, which was highlighted with the triangles, those were elimination provinces which in the early 2020s, most of when elimination was very, very, very exciting to do in Solomon Islands. Those were the areas where most of the data that is published comes from. So we do not really have nationally representative sample of G6PD prevalence. So you would see from literature that it's quoted as 20%. And from the results that are coming in from the current implementation of G6PD screening, although small, is showing about confirming that it's about 15 to 20% prevalence using the SD biosensors. So the big problem of now that everybody, because previously when we introduced primaquine, like as part of a community education and all these things, we also highlighted the risks of hemolysis. And this has actually reduced the impact of radical cure because patients are also a bit reluctant to take primaquine because of the expected adverse events. This practice not only affects radical cure, but does also delay elimination progress as well in the country. On that note, I can say that in the recent years, we've had about, just to give a comparison in terms of what the caseloads are like, about 125,000 cases of confirmed malaria, of which 60 to 70% of those cases are Vivax. So we do have a significant amount of Vivax in Solomon Islands. And like I was mentioned, I think highlighted very well by Dr. Penny, I think we really need to make sure that the SOPs, trainings, and QA systems are improved, and to introduce digital integration in terms of reporting. And one important thing as well is the issue of sustainable financing. I mean, as we know, these reagents are not cheap to procure. Although I think one of the good things is recently the government has sort of made a commitment that they will expand on the G6PD screening services and try to get as many analyzers as they can to cover most of the 370 health facilities in the country. But I think one of the bigger issues is this sustainable financing. It's a very good initiative, but how can we maintain it into the future to achieve and maintain zero malaria in the country? So one of the questions we are pondering over is whether we should do a universal testing or just in targeted areas. Of course, there are the economics of it and all these other arguments. But for what level risk is acceptable to accelerate elimination in the country? Thank you.
Thank you. Thank you, Dr. Lindis, for a very structured and talk and clarity of the message. And especially you raised the issue that when you don't have data or you are not able to do the testing, it leads to very conservative prescribing, which is very, very true. We see in many places that for the fear of hemolysis, many times the primaquine or atominoclinins are not prescribed by clinicians. And also you raised the issues of surveillance gaps or the integration into the DHIS2 data. I'm sure most of the countries are facing these challenges, but someone very rightly pointed out in the chat box, I was looking at that although the progress is slow, but surely there will be progress with the new technologies and also new methods of learning or sharing information. So we should be hopeful. And thank you once again for sharing your perspectives. And we'll have you raised very important questions also. Maybe we'll have those addressed at the end of the webinar or after all the presentations. Thank you once again. Okay, so now we move to the next presentation, and our next speaker is Dr. Mary Malai, and she is a clinical research fellow, PNG Institute of Medical Research. She has led the implementation of Partnership for Vivax Elimination PAVE and also the SCOPE study, which assessed the operational feasibility and cost effectiveness of introducing revised case management for patients with 5X malaria to inform national anti-malarial policy and practice in PNG. Over to you, Dr. Mary.
Thank you, Nina. Hello, everyone. So I'll just share my slides. Okay. Okay, thank you, everyone. My name is Mary. I work with the Partnership for Vivax Elimination Study in PNG. And today I'll just be presenting on some of the challenges, gaps, and opportunities with quantitative G6PD testing that we found during the implementation of the study. So in PNG, malaria remains an important cause of both acute and chronic illness, and PNG accounts for over 80% of the total malaria cases and more than 93% of deaths from recent malaria statistics. And from this map, as you can see here, majority of the cases are at the coastal region or a high incidence, and we have fewer incidents in the colder, more highlands regions. And this is incidence per 1,000 of non-plasmodium falciparum malaria detected by RDT. And these results were shared from our colleagues at the National Malaria Program from National Health Service data. So there are a few challenges, important challenges to malaria control in PNG, one of which is this high burden of Vivax. And we've seen that from recent studies, majority of these cases are hypnozoid-derived relapses, responsible for over 80% of all the cases. A proportion of these cases are in the remote and rural areas, so they do have a difficult time accessing adequate healthcare, and therefore there's a low adherence to this current 14-day regimen of Primaquine that's being used in the country. We're also not routinely testing for G6PD, which also leads to this ineffective Primaquine treatment currently being prescribed. And because of the Chatham strain that is endemic in the country, we do see that there is a need for a higher dose of Primaquine. So in addition to some of these challenges, there are also major gaps in evidence that need to be addressed, such as this lack of robust data on prevalence of G6PD deficiency in the different parts of PNG. Again, just mentioning that there's no experience using this point of care G6PD diagnostics to guide Primaquine treatment at the moment. So we do need evidence to drive the implementation and scale up of G6PD testing and effective Primaquine treatment regimens. So this study, feasibility of high daily dose short course Primaquine after G6PD testing for the radical cure of Vivax, or the SCOPES for short, aim to address some of these challenges and gaps that previously mentioned. And the main aim or the overall aim of the study was to determine the feasibility and cost effectiveness of introducing this revised case management package to facilitate well-tolerated and effective radical cure of patients with Plasmodium vivax. And this map just shows the 4 health facilities where the study was conducted in PNG. So the main component of the study was implementing this revised case management package. The first part of which was to introduce G6PD testing using a point of care quantitative device, which you can see pictured here, the SD biosensor, prior to administering a Primaquine dose. So after G6PD testing, Primaquine was then provided according to the activity level. So there were 3 categories. If you were within the normal range, you received the 7-day treatment regimen. If you were categorized as intermediate, you received the 14-day treatment, and deficient cases were given weekly treatment for 8 weeks. There was also improved patient counseling tools and processes used to help educate participants on the risks and benefits of Primaquine, and we supervised the first dose at the health facility. Community-based clinical reviews on day 3 were also conducted to ensure adherence to the treatment and also detect and manage any adverse reactions. And improved malaria-metric surveillance and pharmacovigilance was also implemented. So in terms of procuring the G6PD test kits, we partnered with procurement agents such as Partnership for Supply Chain Management. Orders were placed, and it took about 12 weeks to arrive in country. Our teams also had to gain import clearance and regulatory approval from appropriate authorities before bringing the kits in. They were delivered to a central facility storage and then later shipped to the study sites for use. So one important aspect of using the test kits, and as mentioned by previous presenters, is the quality control, ensuring that the kits were fit for use. So each time the kits arrived in country, a quality control test was conducted both at the central facility and at the study sites, and then on a monthly basis after, and quality control logs were maintained. We stored the kits in cool rooms at the central facility and at solar fridges at the site to try to maintain them within the correct temperature range. And reporting systems were in place to flag any issues with the kits. And during the study, we didn't see any issues throughout. So again, as mentioned by previous presenters, training was a very important component. Staff were trained in person on conducting G6PD testing, and it took about 2 days overall to complete the training. Refresher trainings were also done in person during each stage of the study, and the trainings were broken up into both theory and practical sessions. The theory sessions involved going through the standard operating procedures around the testing itself and conducting the quality control test with a short competency evaluation done at the end. And practical component involved performing the test and just practicing how to do the quality control procedure. So now I'll just share some of the challenges that we saw during the implementation of the testing. But for that, just quickly share some of the preliminary data on the G6PD prevalence and distribution that we saw or that we've seen during the study. Majority of all the cases were about 92.3% of all our participants screened. As you can see from the pie chart, we're within the normal range. The intermediate group made up 4.8% of all patients, and the deficient group were at a low prevalence of about 2.9%. Distribution by gender, majority of all the deficient cases were male, and majority of the intermediate cases were female, which was an expected finding due to the genetic nature of the disorder. So I think as Dr. Linda mentioned, one of the important considerations as well is the cost of the testing, and as it would help to also inform the national program for future rollouts. At the beginning of the study, when we started procuring the kits, the cost of one of the analyzers was about $300 USD or 1,240 kina in local currency. And for one of the boxes of the 25 test kits, that was 18 USD or 77 kina. So these prices were paid earlier in 2022. And should be slightly cheaper when procured for wider programmatic implementation. So one major challenge that we faced during the study was to do with the supply chain. Procuring and storing the devices could prove to be a bit logistically challenging because PNG is a country where not all the provinces are connected by road, so it meant shipping the kits out to the sites by air most of the time, which was challenging at times, and also ensuring that they were stored within the correct temperature at the sites was a challenge, and meant purchasing solar fridges because of the inconsistent electricity that is sometimes seen in the country. Another challenge we saw was that the shelf life of the kits and controls was quite short, so we had to continuously place orders and keep an eye on the expiry date. Because of the long wait for the next shipment, it meant ordering well in advance to ensure we had kits within the correct date range. And just to mention, we also looked at trying to do temperature testing of kits left outside of the fridge to see if they performed the same, and they did. Kits that were exposed to over 30 degrees did pass quality control testing. So at the moment, we're still doing ongoing testing to see if these kits that are left outside of the fridges are also reliable in terms of providing accurate G6PD results. So in terms of staff training, the staff trained initially on using the device required close supervision and support in the first few weeks to ensure less errors. However, as we implemented the study and over the next few weeks, they required less supervision over time and became more confident with the procedure. So training went well. Majority of the staff passed the short competency test, and that staff themselves expressed that they found the testing generally easy to perform and just needed more practice. And any staff who had difficulties during the training were given more opportunity to practice, which helped them to eventually pass any repeat competency testing. So overall, all the staff who attended the initial trainings grasped the theory and practical aspects well. So in terms of safety and confidence of the testing, the second blood test for G6PD activity after the initial malaria diagnosis RDT test was generally accepted, and additional time is also manageable. And we found that G6PD testing does reduce the risk of adverse events. One important note during the study was that the healthcare workers did find it a bit difficult to communicate G6PD to participants, as it was a complex scientific term, and especially translating that into the local language was a bit challenging at times. However, healthcare workers did find ways to use HP test as a comparison to help describe the importance of G6PD and how G6PD level is something that patients have no influence over. And in terms of minimizing hemolytic risk, we found that the test was generally reliable in terms of providing higher dose Primaquine with no adverse events associated. So these are just some healthcare worker perspectives that were shared by some of the healthcare workers interviewed during the qualitative component of the study. Generally, the main point that was raised by health workers across all the sites was, again, just explaining G6PD participants and the importance of the second test, as some patients were still reluctant and confused for the need for a second finger prick after the initial malaria RDT test. But in general, healthcare workers were in support for G6PD testing, as they felt more confident in helping them to prescribe Primaquine based on G6PD test results. So in conclusion, Plasmodium vivax remains a major threat to the malaria elimination goals in PNG, and implementing G6PD testing to guide optimal dose Primaquine treatment will be crucial to addressing this persisting high burden of vivax in PNG. So the SCOPE study that was conducted has shown that G6PD guided high dose Primaquine with day 3 clinical review is safe and operationally feasible, and that the biosensor test has proven very useful in obtaining G6PD results to guide safe Primaquine treatment. So the key challenges that we noted were around supply chain management, training, educating patients, and the importance of testing and continuous safety and quality control of the test kits. Finally, the PNG malaria treatment guidelines are currently undergoing revision to include this G6PD guided high-dose Primaquine for radical cure, with phased implementation being planned. And finally, I would just like to thank all of the partners who have made this work possible. Thank you.
Thank you. Thank you, Dr. Mary, for this outstanding presentation, which is very self-explanatory. And also you mentioned that a higher dose is required, so therefore the testing is all the more important. And also the issues related to procurement, quality assurance, as also the training. And of course, in the training, you mentioned very positive aspects, and that it was very well taken and people understood. So I'm sure these experiences really help when other countries are trying to implement or adopt or conduct training aspects. So thank you once again. Thank you to all the speakers. And now, although I don't see many questions, but yes, there are a few which I will just go through in a moment. But before that, actually, Dr. Lindis had raised two questions in his presentation in the one of the slides, and one, of course, I find very sensitive question, and I can request the speakers to all of you to answer those. So one was the level of risk acceptable. I mean, this is a very relevant thing, because if we are not able to do, or we have not been able to do G6PD testing, so I mean, depending on the what is the percentage of deficient population, or in areas where there is deficiency and in other there may not be. So without testing for G6PD, if we want to go to new regimen or shorter regimen or higher dose regimens, so what level of risk is acceptable? So before I give my opinion, I would like to ask the panelists. So Penny, can I go to you first? So what level of risk can be acceptable from program perspective?
Right, this is always so.
Difficult one.
It's a very difficult question, because it's a question of public health versus individual risk. The risk is taken at the individual level, and the only thing that I think that we really need to do is empower. I cannot answer that question, Dr. Lindis. That's a difficult question to answer. But I think what we as a public health community must do is patient information, tell people what the risks are, what the signs of AHA are, tell the health workers what to do, and not just, and what they should do if somebody comes back complaining about dizziness, weakness, dark urine, or whatever it is. Just put into place the safety net, because even if we do introduce G6PD testing everywhere, people will make mistakes. It's human, either to transcribing error or something can go wrong. So the more we can empower patients and communities to understand that these are the potential risks, and this is what you need to do, and the health system knows how to respond to that, I think that is going to be a very important part of rolling out G6PD testing.
Thanks, Penny. Dr. Mary, your perspective?
Yeah, thank you. I agree with what Dr. Penny said. I think yeah, there'll always be risk involved with G6PD testing, and yeah, I think it's just how we go along and see eventually, like for PNG, it'll be a phased rollout over time. And so it would be, yeah, like we would look as we go and put, like Penny mentioned, safety, try to make it as safe as possible from the hospital perspective to support any adverse events that do happen during the rollout. But yeah, I think that's just what we've seen during our study and what would be the plan going forward. Yeah.
Right. Thank you. So, Dr. Linders, would you like to comment on your own question which you raised, or comment on what Penny and Mary said?
Yeah, thank you. I think their response has been quite clear. I was discussing with some of the colleagues, I think from APMEN as well, in terms of developing this options assessment toolkit, which does sort of guide management for Plasmodium vivax. And I was suggesting that probably, I think fortunately for us in Solomon Islands, there was a period of time which we were giving very low dose primaquine without G6PD testing. And probably one of the important questions that can be asked during patient review before treatment is history or exposure to primaquine. Just a simple question to say, have you been exposed to primaquine, and did you have hemolysis or changes in urine color and all these things? I think that would give a bit more confidence in prescribing primaquine, that the patient has already been exposed without any adverse events. But that has to be integrated into training programs as well. How can you determine without testing the risks of a patient having hemolysis? Having said that, just a quick look through our data as well, we see that, the effects of malaria itself and other nutritional factors on the patients we see with Vivax, they come in with, significant lower levels of HB as well. And that, I think, is an important thing to make health workers aware as well, that you have someone who's coming in with malaria, has a risk of anemia, and maybe primaquine can aggravate if the patient does go into hemolysis. So those adjunct treatments must also be considered as well, not just thinking about primaquine only with its risks. Thank you.
Thank you, Dr. Lindis. And like from my perspective, when we think of risk, of course, in any medicine or new medicine, we talk about ADR, what percentage, high, low, or it is a rare event or something. But as Penny said, this is a public health aspect. If we consider that, so even if one thing goes wrong, and even if one patient has some issue, the whole program can derail, because as it is, people are very conservative. They are worried about, the issue related when we are working at community level. So, we just, it's difficult, as I said, to answer how much risk is acceptable. But in program, one is very, very careful on these aspects. So even a slightest risk may not be acceptable, because they have been working otherwise also. The things is that Vivax is being treated, although we don't perceive how much is relapse, or when we are talking about elimination, it's a different scenario. We need more tools, but definitely we have to take care and have minimal risk involved. So Penny, you wanted to comment on this aspect
I
or
just
any other?
I just wanted to add, so Glentis, you're right about the low hemoglobin, because as you might be aware, the G6PD test result is not reliable if the hemoglobin is below 7 grams. So that's another aspect that one needs to consider. One thing that was tried in Brazil is that the ministry gave patient cards. So if they were deficient and they came back with their deficient card, then they were not retreated. And that was a very clear indication because the G6PD deficient status does not change. And for females, they were retested if they were either intermediate or normal because of the risk of heterozygous females. The only concern we had is that very few people came back with their patient card, which was surprising. So that's why we were not sure how useful it was when scaling up, because that's another thing that one could consider using.
Yeah, ultimately, when you introduce, I mean, this is a habit which has to be inculcated, and patients need to know how important it is, and that definitely helps. Yes. Thank you, all of you, for these inputs. And there was another thing, I mean, related to qualitative versus quantitative. I think that is easy question. I mean, when we were talking about using primaquine in low dose per day and 14 days, qualitative tests would also be fine. But when it comes to higher doses or short course regimen or tefenoquine, I feel, I mean, that is why we now looking for a good quantitative point of care test, because those new tools cannot be used safely unless we do the quantitative testing. So that is for sure. Anyone would like to comment on this aspect, or I can go to the other question? Okay, fine. Fine, thank you. And again, not a question, but a very good comment related to that. In addition to the training aspects, or at the community level or other counseling of patients. So what Penny you said, I mean, it adds to that. So definitely, this aspect has to be there, that patient also needs to be told that this test is done, how important it is, and we will decide your treatment on this. And in the studies in India also, we found that aspect is important. So there was someone pointed out that aspect in question Q&A, and that's really important and worth discussing also. And so, Dr. Mary, there was you mentioned in your presentation that some of the kids, you try to keep them at higher temperature for some time, and then they tested that. And so there was a question that how long the kids can be kept for temperature more than 30 degrees. And also if what happens if have you experienced that if samples were tested twice, whether the readings were reproducible? But one point I would, before you answer, I would like to mention here that when we are using any test, I mean the assurance from the manufacturer is only what is written on the label, that you have to keep the kids at this temperature. If we are using at high temperature and there is, or we are testing them that they work well, still either the repeat study or something related to label change, or otherwise, I mean, if the readings are not correct, the manufacturer will not be held responsible. So some perspective on this. I mean, definitely this is an important issue when we use at the field level too, like for RDTs initially we had. So any further comments on this aspect and clarification? Over to you, Dr. Mary.
Yeah, thank you. So for the test kits that we left outside of the fridge to just to do some temperature testing to see if they worked as well as the ones we were monitoring or keeping in the fridges, I think the longest that we kept them outside and did repeat testing, because we did monthly testing. So I think we have results from over a 6-month period of this temperature testing that was done on the test kits, but I'll have to just check that again. But yeah, overall, all of those test kits that were left at all 4 sites, they all passed the quality control test. So they were all within the range of the quality controls that we were using, the control test that we were using. So I think we were just mostly looking at that as well, because as I mentioned in the presentation, electricity in PNG is quite challenging in the remote and rural areas. So having, just having that also would help us to see if we could potentially leave some of the kids in a more hotter environment above 30 degrees, because PNG does get quite hot at times. So that was just kind of the basis for why we tried to explore that option as well. So just to answer the question, over a few months at all 4 sites, we did testing, and majority of the kits did pass the quality control. But we're still doing further testing to reach a conclusion on these findings.
So comments from any other, Dr. Lindes or Penny on this aspect on temperature stability?
No, I agree with you, Nina. That's what the manufacturer has put on their guidelines. But I do know, for example, when it was rolled out in Brazil and it's being rolled out, most facilities do not use fridges, and the G6PD test kits are being kept in normal room conditions, and it gets pretty hot there as well. So although there is no data, and it's good to know, Dr. Mary, that you actually have data to show that that there was no degradation of the G6PD test kit. But the reality is that it will be stored without air conditioning anywhere, without fridges, and therefore be exposed to higher temperatures.
Yeah, thank you. Thank you. So, one aspect which again is lingering for a long time, I mean, in the programs, is related to hemolysis. That what happens when we are giving the primaquine or atominoclins without testing, which is happening in most of the programs for so long, and whether how the patients can be informed about it, that there could be hemolysis, and also there was one comment that why shouldn't we ban the medicine which can cause hemolysis? But I'm sure that we are not discussing, because we know we have to see the risk versus benefit for any medicine from that perspective. And this was even debated in WHO guidelines many times, that if when we did not have these tests, that you have to consider what is the risk of relapse and what is the risk of hemolysis. But Dr. Lindes, would you, from program perspective, would like to say that when till date we have been using without testing for G6PD, and how do you think patients were being informed, or did you notice any adverse events or any accidents related to hemolysis when these medicines were being used without G6PD testing, Dr. Lindes?
From my recollection, since when we did the 0.25 milligrams per kg, the low dose, we haven't had reports of hemolysis. But having said that, that's why I was highlighting also in my presentation that pharmacovigilance systems should be high on the agenda as well, so that these can be flagged, because sometimes people interpret those as just part of the sequence of malaria, that you would probably have dark urine and all these things, or attributed to severe forms of malaria. So they don't regularly report in terms of adverse events. But from my experience as well, we did do a study here on Guadalcanal. And what I would also like to highlight is that despite it being a study environment with rigorous follow-ups and monitoring of patients, we did have, I think it's published, we did have 2 patients that were deemed as normal, and through the normal screening, like through the previous generation of the SD biosensor, plus a qualitative test, and they did have hemolysis, which required admissions. So despite all our efforts, I think monitoring and good clinical practice is still very important, despite having a test that can take away a bit of our or bring more confidence, but still clinical practice should be paramount in terms of basics. That's what I can say. I think I'll just respond. I just saw here as well in one of the questions by Sarah. She was asking about the machines, and I think it's related a bit to what Dr. Mary experience with, their study that was looking at temperature. For us, our situation, it wasn't actually the reagents that were faulty. I think it was the actual machine. And my question would be that, how hardy are these machines in our subtropical or neotropic environments? We did send it back to SD Biosensor, and they came back and told us that no, it's out of warranty now. We cannot do anything. We cannot replace it. We can just send it back for you guys to dispose of it if you want to. So like, I mean, that's more my concern is the actual machines. How hardy are they in terms of how good can they survive in these kind of conditions, you know, very high humid areas, high temperature. So that is something I'd be interested to find out experiences from other countries in terms of the machines themselves, the actual analyzers, not so much the reagents. Because we did go through and test everything with different controls, and they all put out the same reading, the same error, which indicated environmental issues. And this was confirmed by the manufacturer as well.
Yeah, I think that is very important. That is why we say when we talk about any tool, I mean, when we talk about operational feasibility, these are the questions which need to be answered and challenges. And that's why, I mean, we were also, when the studies were being done, talking about that what is the right level of health facility where we can use these. I mean, because of course the machine as well as reagents and the kits, they also need to be stored for some duration, so that and I was about to ask Penny, but she has already raised her hand. So over to you, Penny.
Thanks, Nina. Thanks, Dr. Lindis. You're right. I mean, they definitely, I think the percentage of problems with devices is relatively limited. However, that is why in all our studies and also all the countries strongly recommend to have backup analyzers. That you have backup analyzers, that you, whatever number of facilities, and add a certain percentage so that you can then replace it if there is a defective device, because that definitely happens. Not that frequently, but it happens. I think the other thing that we should also be aware of is to have clear instructions for the health facilities that in event of a stock out of G6PD test kits or a defective device, what is the recommended treatment? Because I think that's something that is also important. So if there is no G6PD test, do you then go back to the 14-day Primaquine 0.25 milligram, or what do you do? But it is important to have that kind of advice and guidance to health workers so that you don't have inadvertent use of higher doses without G6PD testing.
Thanks, Penny. And in fact, there is another aspect to when we were talking about hemolysis or pharmacovigilance that, when you want to convince national programs to uptake this new tool or testing, I mean, many times we have faced an answer. I mean, for a long time, we have been facing this answer that uh, we have given billions of tablets and we didn't face any such problem. But the thing is that when it becomes a 14-day schedule, I mean, we are not sure whether it has been taken or not. And if patients have not had compliance, then you won't have the side effect of hemolysis or even the detection, because sometimes it can be mild or they may not be, like some symptoms they may not be noticing. But saying that we could not detect or find or report doesn't, I mean, justify that we don't do the testing, especially now since we have to use the new tool. So there's no doubt about it. But yes, how sturdy are the machines or also the how to store, those are other aspects which need to be learned from these type of feasibility studies. And I'm sure we will have a lot of answers and to manage this. So Penny, while you were answering, there is another question on related to whether, like you mentioned, using these tests at health facilities, there was a question whether we can move to the community level or you also mentioned about that some workers said that about the nervousness in front of community. So the issue was whether it could be moved to that level, although maybe we can debate it from ask other speakers also, but can you first start and respond to that?
So I completely agree, Srihari, with your comment that you have to bring the test down to the community level. And that is critical because that's where we have patients, and referring patients to higher level facilities is complicated and it's expensive for them and it might not happen. So to the second question, it's very interesting. In Brazil, in the Amazon region, as you can imagine, certain areas are very hard to reach. So in certain areas, what they have is they have health workers who go out on motorcycles to communities, and they have red flags if there is a fever case. And in that case, then they take a blood slide, come back to the central facility, which is a smaller health facility, do the microscopy, and if the patient is positive, and it's typically Vivax in that area, then they go back to the patient to give them the treatment. Now, with the introduction of G6PD testing, now the person who was really basically playing a courier service, taking a blood test, going back, and then not being a decision maker, suddenly, if it was Vivax positive, they had to go back with the G6PD test and perform the G6PD test, and then they were in the community. These are very small communities, and obviously somebody comes in with their motorcycle, with a new device, everybody crowds around to look at this. And they were very nervous because they didn't have tables and they only had their motorcycle, and they were putting all the devices, the little buffer and the device and everything. And they got very nervous in the beginning. And they were also nervous because suddenly, they had to make a decision because they had to read the G6PD value and then decide what the treatment was. And the beauty is that they got even more recognition from their community, and they were very proud of it. And it was a very virtuous cycle. But the beginning was difficult for them. And it was very interesting with their responses, because we also did some qualitative research at the end to hear them talk about this and how now they are sort of more valorized by this. It was interesting also, we were concerned that patients would be worried about a second blood prick. And they said, we don't know why they're doing it, but we're very happy. They're taking very good care of us, was the answer. So it really is, it just shows people are valued, communities value it, and health workers find recognition. Now, the question is, how low can you go in the health system, and how far can you make it? I think it's a combination of multiple factors. One is the expense. How many health workers do you have? Can you afford to make it available at that level? What kind of supportive supervision can you do to make sure that whoever is at the community level can conduct the test? Because the big risk with the test is not that it's not conducted correctly. It's just that between drawing the blood, mixing the buffer, and putting the mixed substance on the device, if you take too long for this period, then your G6PD value deteriorates because it's a very unstable enzyme. So essentially, to have a reliable result, you need to do this within a 1-minute time frame. And this is when the challenges come in. So it's not that it's too complicated to be done at the community level. It can be done. Just a question of training and confidence. And the supportive supervision can help that happen. So the decision to use or not to use involves other factors, including financial factors in terms of can this be done. And so I think it should be explored. It must be explored, because that is really where the need is in order to basically control and cure Vivax, particularly in areas where you have the chest and strain, because we know that relapses so frequently that from a patient perspective, it's really important for them and for the community for onward transmission.
Thank you. Thank you, Penny. But yeah, as per my view, I feel when we are stepping into something new, I mean, we can take a little conservative approach and we go step by step. Of course, it has to reach the ultimate level of community. But as I said, the sensitivities in the public health programs, and if even if small mistake or something wrong, I mean, that can jeopardize the whole new uh, tool. So that's why we could be definitely, when like we have experience with RDTs and other aspects, so we can go a bit slow, but yes, we ultimately we need to find out that solution to reach at community level, because otherwise the treatment won't. There will be a gap between the detection and treatment and diagnosis, so that doesn't help. So there was one a question related to PNG, and also Dr. Mary, your perspective on these aspects of the level of healthcare which we could use. And there was also a question that, what is the biggest gap in the evidence that is holding back PNG from introducing these new tools? And in addition, if you like to comment on any of these aspects, especially the level of health facilities where we could use these tests. Over to you, Mary.
Thank you. So I think I agree with some of the points that Dr. Penny raised in terms of bringing it to the community level, because that's where most of the cases would be very important. But as Dr. Penny mentioned, a big factor is the cost and the accessibility of these kits, training of staff, and the confidence that they would have to perform the testing at the community level and then prescribe the treatment. So yeah, I kind of agree with all those points. It would be very useful for PNG as well in the community level, because that's where all the most of our cases would be, and not at the higher levels of the hospital. And sorry, that second question was with regards to
The biggest gap in the evidence which is
yeah.
holding PNG back.
Yeah, so like I think I highlighted in the slides that I presented, one of the biggest gaps is the data on G6PD prevalence. That we really don't have any data at all. So that study that we implemented was to kind of bring that data on the current prevalence in the country. So the program as well to help in terms of planning and future implementation of this new revised case management that we also trialed during the study. So yeah, I would say that's one of the biggest gaps, just some of the data that we would need to kind of implement these changes. Yeah.
Thank you, Mary. And this issue related to data is, I think, common to most of endemic countries. Penny, you want
Yes,
to give some?
I was going to say we have an opportunity in that you don't need to give blood and liver stage treatment at the same time. So we could actually be creative in terms of saying, now mobile phone usage is so widespread. I mean, countries can also consider other options in terms of, say, once a week you have somebody go down to lower level facilities to G6PD test those people who were Vivax positive, because you have a period to provide liver stage treatment, and that can be done carefully. Because I completely agree. In some countries like Brazil, they have been able to bring it down to the lowest level. In other countries, it's more challenging. So I think this gives us the opportunity to say, even if we can't get the test at the community level, we can put into place systems whereby the test can be moved to the community levels and make that happen. So I think that's what our focus should be on, is finding pragmatic solutions to improve access to well tolerated and shorter and more effective radical cure.
Yes, very true. Definitely. And I think today's discussion and other feasibility studies will definitely give us a relevant answer for that. So I think we are heading to the close end of this time. So maybe other questions can be answered later, or if there is any burning question, if any speakers have noticed and which I may not have noticed, you might go ahead as well. But I think most of them are covered. Fine. Okay, so Dr. Phone, you would like to go ahead with the poll?
Nina, can I make a closing comment?
Sure. I mean, let people answer the poll. I'm just waiting for a few minutes. And I could see almost more than 120 participants. They are here until the end of the seminar. So still people are responding. So thank you all, speakers and participants, for the active engagement. And of course, I would like to thank our expert panel for sharing the experience from the field and on the feasibility and access, because this is very relevant. I mean, having a new tool is easy, but applying it or using it in the field needs a lot more experience and hard work, and especially the training aspects which have been discussed, which will definitely help other countries. And these implementation process is sometimes long, and we need to know the experience from the others so that you can safely or confidently use them in your own countries. So thanks once again to everyone. And before I end, let me take this opportunity to wish you all Merry Christmas and a very Happy New Year. Thank you once again. Goodbye.
Thanks, Nina. Thank you, everybody.
Thank you.